Hello there and welcome back. So this is a lecture on the principles of radiologic interpretation. This is probably the most important lecture as far as my courses and getting you started into interpreting and diagnosing from radiographic images. So pay a lot of attention to this. Some of it may not make a lot of sense until you've seen some of the other lectures, so I would recommend going back to this after going through the rest of my lectures and really reviewing some of the cases in here, as it highlights really important processes in your thought process and coming to a radiographic diagnosis. So hopefully at the end of this lecture, you'll be able to at least be able to describe things. That's kind of the main focus of this lecture. And to describe it, that's what leads you into that differential diagnosis. So we'll talk about what radiographic signs really point toward malignancy versus benign things, and so on and so forth. So why is this important? Failure to diagnose is one of the most common reasons for dental malpractice claims. So it's really important to be able to diagnose. That doesn't mean you have to be perfect, but at least give a reasonable differential diagnosis. As you know, with legal claims, it has to be shown that your level of treatment was far below what's accepted as standard. So with that said, image interpretation is not necessarily diagnosis. Your diagnosis is not made without collecting all of the information available, the clinical information, your testing, as well as a histopathological diagnosis. It requires all that to come to a final diagnosis. But it is paramount to the dentist's role in diagnosing. And so what it is an explanation of what is viewed on a dental image, describing and coming up with a differential for anything that shows up in an image, whether it's benign or malignant, whether it's strange anatomical variation. It does need to be noted and at least described and given a differential to a reasonable degree. All right, and these are my references. Do look at that book, The Mullion and Lamb, White and Farrow's Oral Radiology. Then also I use some things from the internet, some interesting images. So do read this chapter. If you're one of my students, read chapter 18 from White and Farrow. That goes along with what we'll be discussing today. If I have some abbreviations that don't make sense, hopefully this will help. Well-defined, ill-defined, corticated, non-corticated, and radiolucent, radiopaque. All right, some of you may have seen this video. If so, you might want to skip ahead a bit. But if not, take a look at this. I'll provide a reference once I post this on YouTube. The monkey business illusion.
Count how many times the players wearing white pass the ball.
You're counting how many times the players in white are passing the ball. It's going to be quite a few, so keep up. And is that it? All right, that's it. Did you count all the
correct answer is 16
all the passes? 16?
Did you spot the gorilla?
If you hadn't seen this before, you might not have noticed.
For people who haven't seen or heard about a video like this before, about half miss the gorilla.
Let's show this again.
If you knew about the gorilla, you probably saw it. But did you notice the curtain changing color or the player on the black team leaving the game?
I've seen it before. I don't remember the player in black leaving the team. Oh yeah, early on.
Here comes the gorilla, and there goes a player, and the curtain is changing from red to gold.
So hopefully at least some of you watching this got surprised by that.
You often miss other unexpected events.
What's the point of that in talking about radiology?
And that's the monkey business illusion.
We're talking about attention to detail when you're looking at images, particularly looking at cone beam CTs, 3D imaging. Always think of that as more like watching a movie than looking at an individual image. But even in intraoral radiographs, I see dentists miss things all the time because they're looking at one individual teeth. Maybe they'll look at a couple teeth, and they won't look at everything outside the field of view. And unfortunately, there are a lot of dentists that don't understand anatomy enough to distinguish between nasal cavity, maxillary sinus, the structures that do show up even in intraoral imaging, let alone panoramic radiographs, which show the whole floor of the sinus and posterior of the sinus, sometimes even into the cranial base. Here's another little fun thing. This was trending on Pinterest a little while ago. 9 seconds to spot the cupid. So as of now, you probably had about 9 seconds to look at this. Did you see the cupid? I put this one in here because it got me. I looked at this guy's face. I thought there's no cupid in here. Of course, when you see it, it's pretty obvious. You'll have to go back a little bit and watch that, but his face looks like a cupid as if seen from the side. And then here's another thing to point out. As far as viewing imaging, a lot of it will depend on the context of what's around it. The example I use is in the maxillary sinuses. Something that's fluid dense, relative to other body tissues, that's very low density, and so it should be fairly radiolucent. But compared to the air, which is typically found in the sinuses, that same radiolucent component thing that might be filled with fluid is going to appear radiopaque. So it all depends on what's around it. This is an example of that. What do you see in the first row? A, B, C, D, E, F. Second row, 10 through 14. And so what's this number or letter? What's this character? Is it a B or a 13? And that's that effect of context. That was both the B and the 13. If it's in the line with the letters, you see that as a B. When it was in line with the numbers, you made it out as a 13. All right, so here we are on a little pyramid of getting to a proper differential diagnosis. You start with identifying anatomical structures. That should be a sound base as far as any student, any dentist is concerned. You should be able to identify anything, and that's why I spend so much time and emphasize so much being able to identify anatomy. And for my exams, that's going to be a good portion of the assessment questions. It's going to deal with anatomy and just recognize them radiographically. Because if you can't do that, well, then you don't stand any chance of getting to these next things. The next step is going to be identifying any abnormalities. So you have to be able to identify normal anatomy to tell when something is abnormal. And if something is symmetric from one side to the other, good chance it might just be an anatomical variation, but you do have to be familiar with anatomical variations. And then the step we're getting to today is the third one, describing any abnormalities. We're going to talk a lot about how to describe lesions when you see them. Primarily, are they ill-defined or are they well-defined? And we will talk a little bit about what that means. And so those different descriptions that we'll go through today are what is going to lead you to produce an accurate differential diagnosis. You deduce that by the clinical radiographic behavior of the lesions. And that's why I focus so much on well-defined versus ill-defined. A well-defined thing tells you about the behavior of the lesion, that it's slow growing, that the bone has time to kind of morph and form new cortex around it, which is a lot more indicative of a benign lesion than it is a malignant or a very aggressive inflammatory lesion.
All right, if you're unfamiliar with the movie Karate Kid, this young kid is Daniel-san, and that's his sensei, Mr. Miyagi. Daniel-san's having some trouble with some bullies in school. Mr. Miyagi befriends him and agrees to teach him some karate. After weeks and weeks of just sanding his floors, painting his house, washing and waxing his cars, Daniel-san is frustrated, thinking he's never going to learn any karate. But then Mr. Miyagi calms him down and he tells him, "Sand the floor." And as he goes through it, Daniel-san realizes this whole time he's been going through the motions, learning how to block kicks and punches. And Mr. Miyagi's been doing this to teach him to go through the actions, the muscle memory actions of learning karate. And so what does this have to do with anything? Well, hopefully you realize that after spending weeks and weeks of studying anatomy, and through this lecture of learning how to describe things, once we get to the point of actually diagnosing from what we see in a radiograph, it should be a relatively small step because you have all that foundational knowledge. Of course, I realize that's a kind of rosy scenario that I've painted in my head, and usually what turns out is when we're going over test questions, students face off with me like this and want to argue that, no, it wasn't this type of lesion, it looked like this type of lesion. But hopefully at least some of you get as much out of this as you can, and at least to some degree realize that your diagnostic skills have taken a drastic leap forward. Now when you see a lesion, at least you recognize some things about it that stand out as to what type of lesion it might be, and hopefully get to a point where you have a fairly good idea of different types of things that should be on the differential.
All right, so now that you are able to identify, hopefully, all the anatomical structures in a radiograph, you should be able to recognize abnormalities. And I already mentioned this little hint, this tip of recognizing symmetry from asymmetry. If something is asymmetric, your eyes should be drawn to it. So when do you see that? When you're looking at a panoramic radiograph, you should see relative symmetry. When you have a full mouth series of intraoral radiographs, look from one radiograph to the opposite side, and usually patients are pretty symmetric. It's sometimes surprising when someone has caries on one tooth. Not always, but a lot of times they'll have a carious lesion on the opposite tooth, so you look really closely on that other side. Same thing with periodontal disease and a lot of different diseases that we get. All right, do we see our normal anatomy here? So first test question, first thought question for you. Take a second to look at this, and hopefully you can note pretty quickly where the big abnormality is. Where's the anatomy missing? And hopefully your eyes are drawn to this right sinus, and you're used to looking at the maxillary sinus borders, because when I look at a panoramic radiograph now, my eyes always go to that anatomy. There's so much anatomy up here that you can see. Here we have the nasal cavity. We have the sinus borders completely intact. We have the zygomatic process of the maxilla, and so the zygoma, the zygomatic arch, the pterygopalatine fissure. But on the other side, all those things are missing, including my favorite structure, the zygomatic process. So something is just very destructive over here, completely destroyed the bone. And we're going to talk about describing more specifically the borders, the different signs of this lesion that are going to help us get to a differential diagnosis. All right, what about this one? Here the sinus border's intact over here. Then it starts to get kind of attenuated, a little bit patchy, and then it's just lost. And you have, again, a destructive lesion. Has kind of ragged, irregular borders. It's not a smooth curvature here. Here the zygomatic process is intact, so not as destructive as that last case. All right, what about this one compared to both of those cases? Look at those sinus borders. Hopefully your eyes are just drawn to those sinus borders right away in a panoramic radiograph. And in this case, on both sides, the sinus borders are missing. So does that mean they have a lesion on both sides of the mouth? Is the bone intact here? Yeah, it looks like there's bone around these teeth, but where's that normal trabecular pattern that you're used to seeing? That trabecular pattern is pretty much gone, and so we would call this ground glass. That's one of the more specific descriptors that we're going to use in radiography, but it's generalized, meaning it's all over the bone, probably all throughout the body, but all we see here is the jaws. And so this is a generalized condition. Multiple anatomicals or structures are missing on either side. In this case, it is symmetric, but there's some metabolic change or some systemic change that's altering the bone in this patient. All right, getting a little bit more into the specifics about radiographic description, because accurate description is what leads you to the accurate diagnosis. That's after doing that accurate description, you put on your Dr. House hat, and that implies all these things about this specific type of lesion. Pay attention to the location, because that's a big thing. And that's also a thing I see a lot of experienced dentists ignore, looking at that potential tissue of origin and what type of lesion it might be. The biological behavior, which I already talked about, prognosis. So if something's ill-defined versus well-defined, if you suspect a malignancy, it's going to have a poorer prognosis than something benign. And that also, of course, directs your treatment options. All right, I don't like to use a lot of acronyms, but this is one that I do really like, the lesion acronym, because this covers all the different descriptors to ensure if you follow all 6 of these, you're not leaving anything out of your description when you see a radiographic lesion. The location, you need to describe where it is in relation to teeth, where it is in relation to the nerve, to the maxillary sinus. The periphery, I usually start with this one, the external or the periphery. Is it well-defined or ill-defined? And you can get more specific than that. We'll go into that. The shape and the size of the lesion. Is it round? Round kind of implies that it has nice smooth borders. You know, it's continuously round. It may be oval, as well as the size. Sometimes your description of the location, say it extends from the canine to the first molar, that may encompass size, so you may cover it without explicitly saying it's 3 centimeters in diameter, but you can say that as well. Internal, so the internal structure. Primarily, is it radiolucent? Is it radiopaque? But you can get a lot more specific than that. And when you can get specific with the description, you'll see that that really starts narrowing down your differential diagnosis. And in some cases, I know almost with 100% certainty what something is because of, well, multiple things, but a lot of times it's that internal description. Is it ground glass? Is it more tennis racket in appearance? Is it soap bubble in appearance? And we'll get to those. And then don't forget, this is an often overlooked one, the effect on other structures. So is it slowly displacing things, pushing things apart, which tends to, not always, but tends to be a sign of something benign? Or is it more just destructive where it destroys bone and leaves teeth floating in air? And the way I describe that, that is more a sign of something malignant. And then the last one, sometimes this is left out, but it can be implied. You can imply that it's a solitary lesion if you say a lesion. And so to some degree, this is just to make a nice rounded out acronym, so it spells lesion. But if there are multiple lesions, then you need to say that. Is it solitary lesion or is it multiple? Multifocal, we'll talk about what that means. And so the first step of that lesion acronym is localization. In the case of a localized lesion like this, like I said, it may be implied that it's a single solitary lesion because you describe a lesion here around the crown of this third molar, which is impacted. But we don't see the same thing on the other side, right? You look all throughout the jaws, mostly looks pretty normal, a couple impacted third molars. But as far as pathology, we're really just focused on that area right there. And this second image is the same one I showed you a few slides ago, where it looks like it's affecting all the bones. So it's not localized to just one area, nor is it just specific solitary lesions where it's multiple lesions, but more it's affecting the entire appearance of bone. So kind of the entire morphology of bone. And that's when you start thinking of generalized or a systemic condition. And then this is what we mean by multifocal. If you focus on one of them, it looks like a single solitary lesion, but look on the other side. Oh, hey, it's symmetric. Does that mean it's a normal anatomical variation? Hopefully you recognize this is not. This happens to be cherubism, which I'll show you at least once more in this lecture. But it is distinct lesions as opposed to a generalized lesion. Differentiating from a localized lesion, you have it in multiple locations. So that's what we mean by multifocal. Localization, so also we'll talk about, okay, where does it look like it's originating? And this is a big thing. Assuming it grew equal in every direction, where does it look like this one originated? Here posterior to the dentition, which actually tells you a lot in this case. Is it within the region of where you would suspect an odontogenic lesion? Is it within the region of teeth? In this case, yeah, I would say it likely is, which doesn't necessarily rule out anything non-odontogenic, because non-odontogenic by nature can occur anywhere. But you do want to start thinking of odontogenic type of lesions because they are relatively common. And so the second thing is lesions have a tendency to be found in certain locations. Most commonly things are going to be found in the posterior mandible, so that's not super specific to any one lesion. Some things though are more common in the anterior, and so those are things are good to know about certain lesions because they can help you come up with that more accurate differential diagnosis.
And here's our friendly real estate agent.
What do they tell you? What's most important for real estate? Same is true for radiographic lesions. Location, location, location. So if I see something that's from below the canal, originating below the canal, pushing the canal upward, I'm not going to start thinking of odontogenic lesions because that's not the proper location. So location tells you a lot. Here's a little hint. This slide is very important. I just alluded to this though. Above the inferior alveolar canal, you should start thinking odontogenic lesions because that's where all the odontogenic epithelium is, where the teeth develop. And like I said, it doesn't necessarily rule out a non-odontogenic lesion. A lot of these non-odontogenic lesions can occur anywhere in the body, and they're relatively rare to occur in that specific region. And so the chance of it being odontogenic is just a lot higher if it's somewhere around the odontogenic tissue. What that means in the maxilla is from within the alveolar process, so within the maxillary bone, but not something that looks like it's coming from the sinus and extending into the maxilla. That would be something more non-odontogenic. And then these are a little less important as we go down here. Coronal to the tooth. Does this look like it developed coronal to a tooth? Yeah, so it's probably going to have come from odontogenic epithelium. That can be a lot of things. It could be a dentigerous cyst. It can be a meloblastoma. Those are odontogenic epithelial lesions. And we already covered this one. If it looks like it's something coming from the maxillary atrium or the sinus, it's likely not going to be odontogenic. below the canal, I mentioned on the last slide as well. Like this, is this above or below the canal? That's below the canal. So you shouldn't even have on your differential OKC ameloblastoma. Those are odontogenic lesions. This is a Staffney defect, which I'll show you again. If it's something that looks like it arises from within the canal, well, what are the type of tissues within the canal? It's got to be either neural or vascular. And then the shape of it, the periphery of it, is going to tell you whether it looks more like something benign or not. Sometimes malignancies that are not necessarily neural or vascular, they tend to extend down the canals. And so that can happen. But especially when something's pressing the borders of the canal outward, if it's displacing them, that's going to be a neural or vascular type of lesion. And then in the condylar region, good chance it could be cartilaginous. Osteochondromas are fairly common we're talking about in the mandibular condyles. There's some common lesions that occur there. All right, think for yourself before I give you the answer. Look at this lesion. What do you think is the epicenter in relation to the inferior alveolar canal? Can you find the canal? Do you see the canal? These big arrows may help. That's the canal right there. And what's happening with the canal? Is this a normal canal position in the absence of pathology? No, I've never seen a canal that far down against the mandibular body inferior cortex. So this lesion is pushing the canal inferiorly. It's displacing it, which, what does that tell you about the origin of the lesion? First of all, above the canal, because it's pushing it down. So it's something that arose from above the canal, and it's likely to be odontogenic. And then the borders of the lesion are telling me it's likely something more benign, because it's pushing things around as well, displacing the canal. And so this is likely a benign odontogenic lesion. And this one, could it be a periapical cyst? I don't see anything going on with these teeth telling me that there's high likelihood of a periapical inflammatory lesion, but I couldn't rule that out. This turned out to be a cystic ameloblastoma. We'd have probably OKC on the differential. Those are fairly common as well. And then you might start listing your less common things. All right, think about this one. Does this look like something arising from within the alveolar bone, from within the maxilla, or does it look like it's something that's arising and limited to the maxillary sinus? And what does that tell you about the lesion? So the sinus floor is here, and this is something that's just kind of resting on the floor of the maxillary sinus. It looks like a little water balloon resting on the floor of the sinus, not really displacing the borders of the sinus. Sinus borders will continue to grow or pneumatize over time, and that's just a natural process. And so this is something from the maxillary sinus. It's not an odontogenic lesion. I don't see any disruption of the sinus floor. That's a good indicator that it's probably not something odontogenic. And that last one, by the way, was just an atrial pseudocyst. Most of you probably recognize those by now. All right, what about this one? Location of the lesion, above or below the canal? Or neither, within the canal. Look at the canal borders. They just kind of gently, continuously go around it. Nice, smooth, well-defined, corticated borders to it. But coming from within the canal, likely to be what? Neural or vascular. And the way I describe this with smooth, corticated borders, very round, all those are indicators of something benign. So this is likely a benign neural or vascular tumor or lesion. Likely a schwannoma, just a benign neural lesion. All right, and then the location of the lesion, as I said before, certain lesions have certain tendencies. I said a lot of lesions tend to occur in the posterior mandible, so that's not super specific. If they do occur in the anterior, there are some lesions that preferably occur in the anterior. Central giant cell granuloma is one of those. Typically in the mandible, but also in the anterior, and they tend to cross the midline. But in most cases, anterior to the first molar. Osteomyelitis occurs in the mandible much more frequently. Most of you may know why that is. Why would infection of bone, which is osteomyelitis, occur much more frequently in the mandible than the maxilla? Well, the maxilla is a lot more porous, kind of spongy bone, and it has a lot more vasculature as opposed to the mandible. So there's more limited vasculature in the mandible and more of a dense bone, and that's a big thing that leads to infection of the bone, is that dearth, I would say, of vasculature supplying the bone in that region. So almost exclusively to the mandible compared to the maxilla. Then here's a real brain teaser for you. Periapical osseous dysplasia occurs in what region of the teeth? If you said periapical, good for you. I know some of your brain probably exploded from that one. All right, and when you do get a multifocal presenting lesion, why is this one multifocal? We see something right there. This may be associated with it, but it looks like it could just be a pseudocyst. But then we also see in the mandible, it's extending all the way across the periapical region of these teeth. That one on the last slide, I just said what occurs in the periapical region of teeth, periapical cemento-osseous dysplasia. There's one in this part of the maxilla as well, right around the apex of tooth 9. And so this is just the florid variety, one of the varieties of osseous dysplasia. But there are relatively few things that cause a multifocal appearance. And there may be one or two really rare ones to add to this list, but as you see here, it really limits your list. So basal cell nevus, that is a disease that tends to cause multiple OKCs, multiple keratocysts inside the jaws, throughout the jaws, anywhere. Cherubism, that's going to be one that you have to distinguish from basal cell nevoid, because both of those cause well-defined multifocal lesions in the jaw, but cherubism tends to occur even younger. So I didn't mention this, but basal cell nevoid occurs in young children, but usually from the age of 5 to 20 is when it first presents. Cherubism, usually by the age of 5, the patient knows they has it because this causes well-defined lesions in the jaws, but it also really expands the jaws. All right, metastatic lesions. So if there's a primary carcinoma or any primary malignancy elsewhere, they can metastasize to jaws. Multiple myeloma, which I kind of think of as a variety of metastases because this is a hematopoietic malignancy of the blood, and that can cause multiple lesions throughout the jaws or throughout anywhere in the body. I have one 3D imaging case that shows it all throughout the jaws, but then it's also throughout the skull, throughout the neck. Very, very sad case. And then leukemic infiltrates, they tend to develop around apices of teeth. Especially in young kids and developing teeth, you can see leukemia start to develop at the apices of teeth. And so it can mimic periapical lesions. That's something to be aware of. If you have a young patient, a pediatric patient, and they've got teeth that are just developing, and there should be no reason for a periapical lesion, and maybe you'll see multiple of them, start thinking that this could be a leukemia. And that patient could be tested for it. Potentially you could save someone's life. All right, and this is a big one as well, the external. I said I usually start with this when I'm describing a lesion. I describe the periphery of it. Is it well-defined or ill-defined? And if you're not sure what that means, if you can take a pencil or a pen, or in this case, maybe a fat crayon, because I'll give a little bit of leeway there between whether I'll call it well-defined or ill-defined. But if you can pretty well delineate where that border is, I would call it well-defined. If it's harder to delineate, here we have some radiolucent lesion, and I can't really see nice, sharply defined borders like I did up here. I might come in the first time and say, and my head's covering part of it, these are the borders of the lesion. Someone else might say, no, I thought it extended all the way out to here. And so you're not really sure where those borders end. You can't cover it with a fat crayon. That's more your ill-defined. And then I mentioned this, but that's an important point. The tendency of well-defined, especially corticated lesions, tends to be benign, so a cyst or a benign tumor, versus the ill-defined lesions, these ones with a really blended border, they tend to be malignant, or in some cases, an acute inflammatory process. Even a chronic inflammatory process, sometimes they'll have ill-defined borders. And this is what I mean by corticated, so I've said that word a couple times already. If it has this thin radiopaque line around it, that's what I call a corticated. And corticated necessarily means that the lesion is well-defined, but not all well-defined lesions are corticated. You see in these cases, you have these well-defined lesions. They have nice sharp bordered, even smoothly round borders, but they're non-corticated. In this case, when it's multiple small round lesions like this that are well-defined and non-corticated, I'm going to call it punched out. It looks like little paper punches, right? So a sharp boundary, but no radiopaque line. And that alone is pretty specific for probable multiple myeloma, but you would be thinking some of those other things that I said cause multifocal lesions. This could be another type of metastasis. It could be Langerhans. But for now, focus on the description. Well-defined, ill-defined, corticated, non-corticated. Then a lot of times people use the term sclerotic, kind of interchangeable with corticated. I'll just tell you my thought process on sclerotic is a more thick radiopaque band around it. So where the yellow arrows indicate here, yeah, that looks kind of corticated here, but you have more of a thick band here. This one's even better. So if you think of a thick cortication, or sclerotic is a term I'll use to describe when bone is, well, it's becoming like this, more radiopaque. Even if it's somewhat diffuse, I'll describe that bone as sclerotic. So all that means is sclerosing or condensing, the bone is becoming more dense around it. And here my image is kind of in the way, but you see a little bit of a sclerotic border around this periapical lesion, which has a radiolucency at the apex. All right, radiolucent rim. When there's a radiolucent line around it, as you see, this is an opaque lesion. So when does this apply? This will typically apply when it's a largely radiopaque lesion. And then you see the radiolucent rim around it. Then we see an external periphery that has a cortex around it as well. But radiolucent rim is somewhat specific. This, if you want to follow that link, links to a paper that talks about this sign of having a radiolucent rim around it. And they mention 8 specific lesions that are identified to have that type of radiolucent rim. Seminoosseous dysplasia, which I talked about. Well, the different types of seminoosseous dysplasia make 3 of them: periapical, florid, or focal. Then ossifying fibroma, then the osteoid osteoma, osteoblastoma, odontoma, and cementoblastoma. Now, if you already have some experience, you may be able to identify which ones these are. And this first one, the one on the left, is an odontoma, so that's one of those. And this one was a semenoblastoma. That was another one that they had on their list. But yeah, be able to recognize that radiolucent rim around it. I will do a lecture that's specific to opaque lesions that have radiolucent rims. So I like dividing up my lectures by the radiographic presentation, because that's kind of when you're going to start, right? You're going to go through this lecture and hopefully be able to describe. Then you're going to say, okay, I described something that's well defined. It's radiopaque internally, but it does have a radiolucent rim. Now let's go to that lecture where Dr. Mecham talked about those lesions with radiolucent rims around it. So hopefully that helps out coming to a proper differential diagnosis. All right, and this is what we mean by ill-defined. This is that image I showed before where we really couldn't find the borders of that lesion. Does it end here, or does it end here? Or does it extend all the way to here? And so that's kind of your classic ill-defined lesions where the borders are kind of blending from the internal to the external portion of the lesion. So blending meaning gradual transition between normal adjacent bone and where is it abnormal. As we see in this case, it doesn't always mean that something is malignant. This is just an inflammation. I said typically malignant or an inflammatory process. So that inflammatory is the big exception to that. Another one might be what we see right here. So this has a blending border. It's also just kind of cloudy in here, just kind of a neutral cloudy gray, mostly radiopaque, but not excessively opaque, right? And that blending border with it, this is what I'll describe as ground glass. If you look very closely, you might see little kind of interchangeable particles, looks like salt and pepper maybe. And that's what we mean by ground glass. And this is fibrous dysplasia, another thing that's not necessarily malignant, but it also has an ill-defined periphery. Just some more examples. Invasive might be another term you use when it's really invading into different structures. This one I might describe as ill-defined and invasive. You could also describe it as blending, so there's no black and white between when you use one term or the other. But invasive is when I think of it really invading into the marrow spaces, invading into the bone, invading into certain structures like PDL space. Malignancies love to do that. But if you describe these as ill-defined, that will set you on the main path. Really, the distinguishing between blending and invasive is not that critical. Describing as ill-defined is what sets you on the path to say this looks like it could be malignant. And that's what you want to rule out first when you see something like this that's just purely radiolucent and has an ill-defined border. And then second, you're going to say, okay, it could be an acute inflammatory process. Could this just be osteomyelitis? Yeah. In most cases, though, osteomyelitis has some degree of sclerosing bone around it, or within it, some degree of patchy bone. This one I really like for invasive. Why? Because of the way it's invading the marrow spaces, kind of widening the marrow spaces, almost like finger-like projections or this mist of darkness invading into the bone. Even the appearance of this just looks very malignant to me, very dangerous. So I think of this as, if you're familiar with Wheel of Time for fantasy fans out there, like the mists of darkness with these fingers that are reaching out. Just very ominous appearance. And that is a strong indicator. It seems like most of the time you see that where it's really widening marrow spaces, it's going to be one of the hematopoietic malignancies. In most cases, this is an older patient, probably lymphoma. But for now, again, just recognize the signs. You've seen this one before. Do you remember it? Is this well-defined or ill-defined? Does it have smooth borders or ragged borders? This is well-defined, smooth borders. Is it solitary or multifocal? That one hopefully is an easy one. It's multifocal. You see multiple of these lesions. They look punched out. And so you go to your multifocal lesions lecture, and hopefully that really narrows down the differential for you. This was that multiple myeloma. All right, what about this one? You look at this side, you may even start arguing this looks a little ill-defined. But again, I said if you have a fat crayon and can draw a line around it, I'll usually describe that as more well-defined. But then especially this side, this is well-defined, and you can even see the cortication around it. And so that's a strong indicator that this lesion is something benign. And so how do you explain the distal part of the lesion right here? Well, anything can get infected, especially if it communicates with the oral cavity. And so any of these benign lesions can get secondarily infected and then start to lose some of that nice corticated border around it. So that's likely what's going on here. But if you see any part of the lesion where you're sure it's not just an adjacent anatomical structure, so there's no canals here that we're going to confuse this with. If we're looking at the anterior maxilla, you got to make sure you're not confusing the border of the nasopalatine duct or the border of the sinus or the border of the nasal cavity as one of the borders of the lesion, because that can cause a corticated appearance, but that doesn't mean the lesion is causing it. But in this case, I know the lesion's causing that, so my differential is going to be limited to typically those benign type of lesions, either a cyst or benign tumor. And this is likely just a residual cyst, as you see the extraction site right here. They extracted the tooth, but maybe that cyst was left in there and continued to grow, because when something is an actual periapical cyst, it has its own growth potential, and that cyst is going to have to be enucleated just like any type of pathology, or it can continue growing.